Good evening, everyone. I'm Belinda Paulson, Vice President, Cancer Care at the Cancer Support Community. Welcome to our live webinar today. For those of you joining us for the first time, I'd like to share a little bit about Cancer Support Community. We are a global nonprofit dedicated to uplifting and strengthening people impacted by cancer. Our mission is to foster connection, compassion, and knowledge through professionally led psychosocial support, navigation services, healthy living programs, social connections, and our award-winning education series, Frankly Speaking About Cancer. These services are offered at more than 200 Cancer Support Community Gildas Clubs, healthcare partner locations, as well as online through our toll-free helpline. When you connect with us, you are supported by licensed community navigators and resource specialists who provide patient navigation, financial counseling, CAR-T concierge services, genetic and biomarker testing, counseling, clinical trial, pediatric support, and much more, all at no cost. For over 40 years, we have been a relentless ally, helping individuals and families manage the realities of this disease and reclaim a sense of normalcy. Today, we're going to discuss endometrial cancer. To better understand this unique experience, we will touch on side effect management, treatment options, and fertility challenges that may arise when diagnosed. We are excited to host today's event in partnership with Endometrial Cancer Action Network for African Americans, also known as ECANA. We are grateful for the generous support from Merck and Asai, who made this program possible. At this time, I get the opportunity to introduce our speakers for this evening. I'm grateful to introduce to us Dr. Laura Chambers. Dr. Chambers is a gynecologic oncologist and an assistant professor at The Ohio State University Comprehensive Cancer Center. She specializes in the care of patients with endometrial, ovarian, cervical, and other gynecologic cancers. In addition to her clinical work, Dr. Chambers leads research focused on how microbiome, diet, lifestyle can impact cancer treatment and survivorship. She has received multiple national research grants and is committed to improving both outcomes and the quality of life for women facing gynecologic cancers. And also today, we will have with us Shanda Foster. Shanda is a 4-time cancer survivor. Oh, there you go, Dr. Chambers. Good. Thank you. Dr. Chambers is here. So before we go on to Shanda, if we are going to give you a moment to just say hello to the audience and share any disclosures or any statements you want to make.
Hi, everyone. I'm so honored to be here tonight. I think this is a great program, and I'm really looking forward to us all talking, and I have no disclosures.
Thank you. Thank you. And joining us soon is Shanda Foster. Shanda is a 4-time cancer survivor who has transformed her personal journey into a powerful platform for advocacy and awareness. During recovery, Shanda discovered the importance of patient voice in shaping how medical professionals approach care and awareness. She now partners with doctors and organizations to help bridge the gap between patient and providers, emphasizing the human side of medicine. Her advocacy work highlights the critical need for education, early detection, and representation, especially among diverse women who are disproportionately impacted by health disparities. Shanda continues to advocate for a future where patients are not only cared for, but also included as key partners in the fight against cancer. Hi, Shanda.
Hi, how are you? Thank you so much for having me today.
Good. Also, if you'd like to add anything and share about you as we begin, you can do so.
Sure. So my name is Shanda Foster. I'm from Boston, Massachusetts. Go Celtics. I was actually diagnosed with stage 3 endometrial cancer when I was 31 years old. So I was I was on the younger side. And detection was really important to me because I'd gone through a lot of channels where I didn't have that opportunity. It was the symptoms sometimes are not necessarily there. And I think I was diagnosed in 2012. So leading up to that with symptoms, things like that, the doctors didn't really know what to make of it because I didn't look like what the standard patient would be for endometrial cancer. I was very, very young. I was a lot thinner. And back then, I think those were two of the things that they were looking for. So I'm just really excited to be here and have this conversation today and to see where advancement has really taken us. It's really great.
Awesome. Thank you. And thank you for joining us. So at this time, we're going to start opening the discussion with some questions. So Dr. Chambers, we're here today to discuss endometrial cancer. Can you kind of start us off by explaining what endometrial cancer is?
So endometrial cancer is a cancer that involves the uterus. The uterus is connected to the cervix, which is the lower part of the uterus, and then is connected from there to the tubes and ovaries. Each of these cancers, each of these organs can all have their own specific cancer, but cancers of the uterus generally come from the middle part of the uterus, and we call that the endometrium. So what I always explain to my patients is the uterus is sort of like a pear, and there's the middle part, the endometrium, which is where the cancers usually grow. And then the endometrium has the muscle on the outside, and then it has a shiny coating. And so most endometrial cancers start from that inner lining, which is why patients will generally have bleeding as the most common symptom. There are some other types of uterine cancers that can grow from the muscle, and we usually talk about those as sarcomas, and those are a little different. But generally, we consider uterine cancer to be cancers that start in the lining or in that muscle. And there are some differences in treatment as well between those.
Mhm, mhm. Thank you. And then also if you can discuss a little bit about any common risk factors.
So for cancers of the uterus or endometrial cancer, we generally think of them in two categories. So there are what we consider type 1 cancers, and these are cancers that are driven to grow because of too much estrogen in a person's body. Some of the typical risk factors are people that have infertility, people that have higher body mass index or are overweight. That can lead to increased circulating estrogens in a person's body. Patients that have irregular cycles. We also know that there's another type of endometrial cancer called type 2 cancers, and these tend to have a little bit of a different risk population. These tend to be patients that are of Black race, patients that have, we know that there are certain mutations that can run in families that can also go along with those cancers as well. There are some endometrial cancers do also run in families, about 5%. The most common family syndrome is something called Lynch syndrome, and that accounts for about 5% of endometrial cancers, and those would be passed on through families.
Mhm, mhm. Okay. And for Shanda, can you tell us about your experience with endometrial cancer? Symptoms, what was your experience, and anything that you think would be helpful to share?
Sure. So I actually am a Lynch syndrome carrier. Well, carrier, yeah. Patient, but it happened on my mom's side that was something that was a genetic mutation on her side. For me, I was very young. I was an athlete. It was not uncommon for me to have very difficult periods to begin with. I did at one point begin having very, very heavy bleeding. In those periods, I think the average period was about 7 days and pretty heavy. Not too serious, anything that really needed attention. But then it began to get worse, and then it started to, I began getting more pain with it. And as the time had gone, the more and more, what I found as an athlete was that I was constantly moving and I was exercising. And so when I would have cramps, they weren't that bad. So I knew that when I was still training and being really, really athletic, as it got worse, it just felt like something was wrong. And I was began getting other symptoms that were, that felt like stabbing in my uterine area. And so, I wasn't, also, I was young. So, I was in college. Um, I was probably in college when it actually started, the symptoms. So these were symptoms that lasted for a long time for me not to be getting diagnosed until I was 30. But I went to see several doctors. And in that time, my periods were increasing. So at one point, just the bleeding never stopped. And so I would go to the hospital and I didn't have health insurance because I was still, the time when you're in college and then you're, now becoming an adult and you got to get your own health care. I just went around looking for multiple doctors and I really found it very difficult. I live in the suburbs outside of Boston. So it's really difficult to get healthcare. And no one really talks to you about that. But when you actually really need to see a specialist or someone that's not necessarily a PCP, you really need that support. And it wasn't until I was in Boston downtown living and the access to medical care was much greater. I was introduced to a doctor, Dr. Susan Schilling, and I talked to her about my period issues, and she said that she'd found a fibroid. And so we thought that that was the issue. And so I went in to have, I scheduled surgery for my fibroids. And about a month later, I went back to her and I was complaining about my really, really painful periods and this bleeding that was just continuous and ongoing and just never stopping. And she said, "You still having that problem?" And I was telling her, "Yes, I'm actually getting ready to go on vacation." And I just was hoping that maybe I would get some type of relief while I was on vacation and traveling. And she said, "We're going to do a biopsy. I think it's really important for us to do that." And I just kind of looked at her whenever I tell this story. I just looked at her and I just thought that was the most bizarre thing for someone to say to me. It did not even occur to me that it could be something that was cancerous. And she did the biopsy. She sent it off. I went on my trip. And when I came back, they were calling me. They said it was very, very urgent. And I came in to the office and she told me that they found cancerous cells.
Mhm.
So it was yeah, the symptoms can be very challenging. And unfortunately, the symptoms mimic other things too, right, Dr. Chambers? So it's not even like you see the symptoms and then you're like, wait, it could be, it could be fibroids. I did have a couple of fibroids. I know plenty of women who have fibroids and, they exhibit the same exact traits and symptoms that I had.
Mhm. Mhm.
I totally agree. And I think one of the challenges too is many, patients will have, they'll have had irregular periods at various points in their life. And I think, it's very easy for us always, we don't want there to be something wrong, right? So I think one of the things sometimes is like many of the patients that I take care of, they will say, I just thought I was having irregular bleeding because I did that before. Or, many patients get close to menopause and they may not really understand that they're supposed to stop bleeding. I've taken care of a number of patients that they never went into menopause, but they didn't really know that that was wrong. Like they didn't really have maybe someone that, no one told them you really should stop bleeding. And if you do bleed again, then you should get that checked out. So I totally agree. And I think the other thing too is just like one of the things that has always drawn me to taking care of patients with gynecologic cancers and women especially is we are the caretakers of everybody else, right? And I think many patients there's always something that needs to be done for their family member, their kids, their husband, their job. Like they're always on the go. And, sometimes they're like, well, I noticed a spot of blood, but I figured it was okay. And then I noticed it again, but it didn't happen again for a little bit. So I didn't really get the time to schedule that biopsy. And, I think what I really try to emphasize to people is any bleeding after menopause is not normal. You really need to get it checked out. But even before menopause, like we know now that more and more cancers are being diagnosed in young people. And if your periods are painful and they're heavy and they're irregular and they're keeping you home from work, like that needs to be checked out. And if you're not being heard, then you need to keep trying until someone will hear. Because um, endometrial cancer, especially if it's caught early, is a disease that we generally can cure with surgery and our other treatments.
Mhm,
I love
mhm,
that you said that. And it just reminds me of because I was at such a young age and I was so ignorant of any of these other issues that could occur. I did let it go. And, I talked to many other, young women and students, because I was in college at the time. And it was almost normalized, like, oh, I have really bad cramps. We talk about that and we hear that constantly. Oh, well, I just have really bad cramps. And there just doesn't really seem to be a definitive line for when it's just too much that you actually really do need to have it addressed.
mhm, mhm. Yeah, thank you for sharing. So I'm really hearing about really paying attention to your body and the importance of self-advocacy. So, Dr. Chambers, what are the treatment and care options for endometrial cancer?
So there are a lot of different options. So we know that when patients are diagnosed with endometrial cancer, our best first treatment is usually surgery. And for that surgery, we typically do a hysterectomy, which we remove the uterus, the cervix, the tubes in the ovaries, and then we do an assessment of the lymph nodes. We have really good research that shows that that surgery can be done minimally invasively. So that's either laparoscopically or robotically. And so most people that are diagnosed with endometrial cancer are going to have early stage disease, and that will be the first treatment. There are some exceptions to that in people that have, if someone comes in and they have concerning things on their exam or their symptoms that they may have cancer spread, then sometimes the surgery would be done as an open surgery through a bigger incision, or there may be some other changes. But generally, we recommend surgery first. We believe that surgery is a big part of the care for endometrial cancer. After a person has surgery, then typically what happens next is everything that we remove at surgery goes to the lab and is checked out by a pathologist. And that's when we understand the stage of the cancer. So, stage is where things spread to. And stage is a big thing that drives the decisions that we make after. When we look at the uterus under the microscope after it's removed, we also look at a number of other things like where the cancer may have spread. We look at the grade of the tumor or how aggressive the tumor is. And we look at a number of other factors, including involvement of the ovaries, the cervix, and then involvement of the lymphatic spaces in the uterus. So ultimately, we do the hysterectomy usually, and then we look at all of these pieces of information. And we have patients that we know are low risk, patients that are intermediate risk, and then patients that are high risk. And when we put patients in those risk categories, what we're doing is really assessing how likely is their cancer to come back. And then when we put people in those categories based on research studies, then we know what treatments they would benefit from. And for many patients, that will be close observation. So we won't recommend any additional treatment. But there are certain patients that would benefit from radiation treatment. And that can either be vaginal radiation or pelvic radiation. And then there are a cohort of patients that have high risk disease that would benefit from chemotherapy, potentially with the addition of immunotherapy as well.
Mm,
So there's lots of options, and everyone has, and it's very, very individualized to each person based upon their final pathology report. So it's always a really overwhelming thing. Like when I meet someone and I tell them, we talk about their cancer and then we're talking about surgery. There's a whole lot of possibilities that could
yeah.
come after. But when we have that final report, that's when we have all the information to make what is the best treatment for that patient.
Mhm, mhm. Yeah, thank you. So, Shanda, you shared a little bit, but if you can share a little bit more on your overall experience in accessing the treatment and their process for making those treatment decisions. Just as Dr. Chambers just shared, there's a lot to share with patients and going through that process of treatment decision.
I think the biggest thing that was the driving force for me was my team of doctors. I actually started out in the community health center space where my doctor was working, and she was a Brigham doctor from Brigham and Women's. But she also worked there. So I was very fortunate to have her. And as I said, I was going away. So when I returned from vacation, I was very, very fortunate. They had already planned and essentially scheduled all of my next steps, which is very unheard of. I went from, I had that first initial biopsy, then I went to a DNC for them to clean out the cells and get more testing. And then from there, I went to a hysterectomy, and I met my new doctor and surgeon and oncologist and team, and that was at Beth Israel over in Boston, Beth Israel Deaconess, which is where I actually still am today. And the team of doctors was just really excellent. They really scheduled and put every peg in line for me. I didn't really have to do much. Except basically show up. And I think that is the testament of a great team. And that's what a great team looks like when you're talking about doctors. In terms of the decision, so after I had that, I did have a full hysterectomy, and I had a course of chemotherapy and radiation, pelvic radiation. And from there, but I also had occurrences. So many of those things, the times that it came back, which is what I spoke to in prior, the advancement of medicine, every time that I had an occurrence, there was a new course of treatment that was available to me that had just gotten greenlit, which is amazing, and I think is a real positive when we're talking about these, talking about cancer and things like that, because it can be very overwhelming and it can be very, very scary, and you're literally holding your life in your hands. But to be able to see the way medicine has moved and the way technology has also has moved is very encouraging to all of us. It should be really, really, it should be, we should talk about it more. I don't think it gets enough praise. But as far as making the decisions, I want to speak a little bit about having a hysterectomy and making the decision to do that, because it is a very life-changing decision that you'd make depending on who's having it. Some people have had children and they don't mind. Some people never really wanted to have children, and some are hoping to. And so that, the options, I think, people don't really talk much about the options. I was actually given the option to go to IVF, and I had a very small sliver of time to go through it and find out more information and really do more research and find out what would be right for me. But it is available. It's available. The team there was excellent, very informative. You had the option to potentially extract eggs if they were viable, and freeze them, and just a lot of really, really great information that I think should definitely be taken into account. But I made the majority of my decisions with my family, and as I got to know my doctor, because she was very brand new, we did not know each other at all. We hadn't had. I was kind of like forced to trust her in a small time frame. But she gave me some really great advice, and I never thought I was, felt like I was alone. And I just kind of had to put myself first for once. When we talk about women constantly being the ones that are on the move, that's true. And I decided that I was really interested in preserving my health as best as I can. And I would look, if I want to have children, I would look, into other means.
Mhm, mhm. Yeah, thank you.
It is, I was
Go
just
ahead,
gonna
Dr.
add,
Chambers.
I was just gonna add, it is a really big decision to have a hysterectomy. I mean, I think that for many different reasons, I think for some patients, whether they're interested in pursuing fertility or building their family, or just for many patients in various like cultural backgrounds or just in some of their beliefs, like keeping their uterus is really important. And that's something that is just it really important for me when I talk about it. You know, we do know that removing the uterus, we do believe that that gives patients the best outcomes, and helps us at like you know, stage the cancer, um, and get all of those additional pieces of data that we need to make the final treatment plan. But it is really challenging for many. And so, you know, I just want to really like emphasize that to you. Like, I can't even imagine how hard of a decision that must have been to have gone from just being, you know, a young, healthy athlete that was just having abnormal periods. And then one day your life's just changed and you're talking about a hysterectomy. You know, it's a really big deal how fast it can all come at you.
Mhm.
True. And I think also too, I talk more to, I have young nieces, they're 20, 21, 24, and I have one that's coming up that's just turning 14. And the more I speak with younger people, I just feel like it's a lot more normalized to have a hysterectomy, and they're so casual about it. And they're like, oh, well, I'll just have a hysterectomy. And, not them specifically, but other young people that I talk to. And of course, friends of mine that, I constantly talk to them about their health and specifically in these areas, and they're like, oh, I'll just have a hysterectomy. And I'm constantly like, listen, if that's the last thing you have to do, then that's the last thing you have to do. Like, let's not put that first, and for many many reasons, like you mentioned. And also too, just the coping physically with the changes that come with a hysterectomy. I just think that's why I'm very very passionate about educating. I think it's really, really important. And I mean, obviously that goes, without saying, but I just think that a lot of people take it so lightly. And that's why I'm here today.
Yeah, we're glad you're here today to really help others learn. Um, and as you were all talking, we talked about treatment. We talk about that there are many options, but can we talk a little bit now about side effects and those will sometimes result from the treatment, right? So I wanted to give us an opportunity. Can you just share a little bit about the side effects?
I think it's easier to sort of answer that, breaking them into the treatments and then what
Yes.
effect. So, you know, for a patient that has a hysterectomy, and then generally we would recommend removing the uterus, the cervix, the tubes in the ovaries. Those patients, if they are premenopausal, they are going to go into menopause. And so surgical menopause is very variable. Some people experience it right away, some people within a couple of weeks. Some people it's more intense than others, but usually that does have hot flashes, or people will have sort of these intense feelings of being very hot that can happen at nighttime that can just feel very unpleasant, associated with anxiety. But even just outside of hot flashes, patients that have menopause, they do have some negative effects on their bone, their brain, and their heart health. And just, I feel like patients just generally do experience some mood-related changes with that. As far as physical things from having a hysterectomy, you know, it's about a 6-week recovery. People will feel tired and just lower energy during that recovery phase. I will always tell my patients the first 2 to 3 weeks are the hardest. That's when you are going to feel more pain and swollen and bloating. And usually by about week 3, people are feeling mostly back to normal, but not 100%. As far as other things with surgery recovery, it's normal to have some bowel related changes, like maybe some bloating, constipation, some bladder related changes, maybe feeling like their bladder doesn't empty as well right away. Those things are common but should get better. Um, I think everyone's experience of intimacy after a hysterectomy is different. Some people do feel that they have some changes or they have dryness, they have pain. Many people don't experience that. I think it's really, really varied, and that's something that I always talk to patients about. As far as cancer treatments in particular, so for cancer treatments, when we give chemotherapy, chemotherapy has various ways that it can be given, but most of them are given about every 3 weeks. In the first week that you get chemotherapy, many people will feel some nausea, lower energy. The day you get chemo, we give medicines that help decrease risk of reactions. So we usually give medicines that make you feel sleepy. So for the most part, the first week, you may feel tired, and the nausea usually sets in at the end of that first week into the second week, typically. You can also have lower blood counts around day 10, day 14 after chemotherapy. Many chemotherapies will have hair loss as well, and then something called neuropathy, which is tingling in the fingers and toes that can be quite painful. I feel like as providers, we will often say neuropathy is tingling, it's not too bad, but it really can develop throughout treatments, and it can, without without being managed in terms of medicines or dose reductions, the neuropathy can become quite life altering. Radiation treatment is different than chemo. So chemo goes in through our bloodstream, it works on all the cells in our body, whereas radiation is localized to an area. And usually that area is the pelvis or the top of the vagina. Patients, when they're getting radiation, radiation is given every day for a period of time. And usually that's 25 treatments over 5 weeks. So radiation is a lot more intensive as far as you're doing something every day for a number of weeks. So most people will have fatigue, or just feel really tired. Radiation can also cause a lot of GI side effects, so diarrhea, constipation, bloating. Those things can be in honestly most patients. And then also some bladder changes too, feeling like some burning with urination, incomplete emptying, things like that. I will say, each treatment has different side effects. It's really important to talk to your doctor. It's also, there's so much information out there in our world now with social media and the internet. So just go online, and there's lots of good things to look at. But I think also we are better able now than we've ever been before to manage side effects from treatment. And what I always tell my patients is, I do this every day, but you do this, a couple of times, really. This is not something that is your everyday. So if you aren't feeling good, if you have symptoms that you can't do normal things in your life, like cook your meals or go and take care of your family, you need to let your team know, because there are a lot of ways that we can manage side effects. I always tell my patients that when we start chemotherapy or immunotherapy, we tend to give everybody a similar recipe initially, just because that's what we typically do. But usually there's some modification that has to be made for each person, whether it's changing a dose or adding a new medicine. And so I think just being really open with your medical team about how you're feeling allows us to really make sure we can tailor it to what you need when you're going through it.
Mhm. Thank you. So Shanda, we mentioned a little bit in the beginning about side effects and your experience, and if you'd like to share a little bit about that, and also, what was helpful for you in navigating these side effects?
Yeah, I was listening to Dr. Chambers talk earlier and mentioning all of the different treatments, and I've had every single treatment. I've had first I had chemo, then I had radiation, then I had a recurrence, and then when I went back for radiation, CyberKnife was greenlit, which is essentially radiation, but it's very targeted to the tumor, and it doesn't cause any damage to any of the tissue around the tumor, just the tumor itself. It's kind of like it blasts it. And then after that, I had another occurrence. And then my last occurrence, which was 2017 or 16, and I had immunotherapy, and that was greenlit. And so, I think it's tough to say. I mean, I look at my journey now, and with the chemo was the most difficult, I think, by the chemo and the radiation were the most difficult by far. Um, One thing I learned about just in general is to research everything. And that was one of the mistakes that I did not do with the very first time. I didn't research anything. I kind of just let them give me whatever that's like, okay, this is what your plan is going to be. I did ask questions, but I didn't really research anything. I kind of just, and not to say that you can't trust your doctors, you do, of course. But it is good to, and it is very freeing to be able to have the research yourself and to know what you're coming into. And one of the things that I've realized is that we're our own advocates. I say that all the time, and I keep saying it because later down the line, some of these things do affect you, and they may not happen in the first couple of years, but maybe down the line, you start to develop little quirks and kinks, and they're not nowhere near as important as saving yourself from cancer, right? But it is something that it has the potential to happen. It may be something that hinders you with walk. I think I developed drop foot in 2017, 2018 or 19. I developed drop foot, but it was as a result of a treatment that I had back in like 2016, 20, so just being able to research those things, I think it's really, really powerful and very, very important. And I was looking and I was like, what is it that I was looking at? Where was I getting these research ideas? And I was just going online. I think the National Institute of Health was really, really important. They had a lot of clinical trials. They had a lot of research that I don't even know if I know my doctors actually had it, but I don't know that they actually read everything that was in it. But I did when I walked into my first treatment for immunotherapy. I was able to talk to my oncologist and tell her a lot of things that I don't think she knew at the time, which speaks to the power of just being able to have the internet at your fingertips and really read. But I think that helped, learning more, talking to other patients also helped. Ikana definitely helped. That was kind of like a saving grace for me, just having our organization of just survivors where we're able to share stories and kind of find out what worked for you, what worked for me, talking to other people who may have developed some of other things along the way and really just understand your journey. And I think also there was a website, and I don't know if this actually still exists, but it's called Hister Sisters. And it was all women who had had hysterectomies. If it is, I mean, if you're looking for information, go to Hister Sisters. I think it'll help. But I read the forums, and it was just lots of stories about from women who were dealing with the same thing that I was dealing with, and ways that they were coping. And it really helped. I would read some things and I would try them out, and I was like, oh, you know what? I feel better. And it was just a really great community. There's nothing like finding another community with, full of people who are going through the same thing as you.
Mhm.
I
Yeah.
I totally agree. I think there's really value in the shared experience of what people are going through. In our clinic, we have a cancer support group that meets monthly. And I think that many people are really drawn to that, and some people are more private. But I also encourage patients to go on social media. I mean, I think that obviously you have to take everything, really kind of research everything and question everything, but there's really wonderful cancer support communities of people talking about their experiences with their treatment and clinical trials and their diagnoses. And I've done some research in social media, and I think it's just a really like valuable community, especially people that may have, they're going through newer treatments that they may not know of people, or they have rare diseases. Um, I just think there's a lot more resources to connect now than there ever was before, and it's really important.
No, that's definitely true. That's definitely true. I'm so glad that we're having this conversation today too. And I will say I was one of those people that I was very, very private. And I did not even share my experience. And I want to say that, like, I would like to add that as an offering. Like, there are a lot of people that are out there and they are dealing with cancer in silence, and they are afraid to tell people, or they're, just maybe keeping it to themselves because it is quite private. And that's okay too. I don't think that there's any one solution that's better than the other. I do think it helps, but I do think it's something that you have to do in your own time. And that is okay, even, with families. And I didn't tell a lot of my family until afterward. But when I did, when I was ready, I went right to social media and I was telling, you know, I was kind of working through my emotions through sharing what my experiences were, and oftentimes like taking pictures in the treatment room and kind of talking about that, and just realizations that I was having from, because I think when we go through these very, very life-changing circumstances, we're reflective, we're very reflective. A lot of things start to come across mind. And you begin to reevaluate those things. And so I think, to your point, like, social media really did help me. And I actually had a lot of people that were reaching out to me, and they would send me messages and tell me that they were going through things, and asking me questions, or what do I think? And a mother, they have someone who is exhibiting the same symptoms but refuses to get tested. And so just the importance of being able to share that is really, really important.
Mhm. Yeah. Thank you. Yes, it's important to share when it's about helping others. So, and your advocacy work is really making a difference. Thank you, both of you. As we kind of are going through this, those of you who are online, now is a great time to drop questions you may have in our Q&A tool as we continue here. So Dr. Chambers and Shanda, if you each were sitting with a newly diagnosed patient with endometrial cancer right now, like we're in the living room, what are a few important things you would want to tell them?
I'll let Dr. Chamber go first.
Um, when I meet someone for the first time, my goal is in that first visit is to try and empower them with as much information as I know at that point. So practically speaking, most people come with a biopsy. And so I think it's really helpful to tell people, what I know about that biopsy. So things like the grade of their tumor. I also just really try and tell people that we have a plan. Like there are so many things that we can do to treat this disease. And we're going to take it step by step. For most people, again, that's starting with a hysterectomy, and then there may be some things that come after. But I really try and empower people that this is something that is very treatable. It has a lot of options, and we are going to walk with you through that. Um, I also really try and talk to people about, some of the risk factors that they may have for that cancer, but also tell people too, like, this isn't anything that you have done. This is a disease it's our most common gynecologic cancer that we treat in the United States. This is very common. And this is something we have a lot of expertise in treating. So for me, it's really important for people to know that, to understand their disease and understand some of the nuances to it, to know that there's a plan in place, that we're going to start the ball rolling on that. And then to know that they're supported. Those are the biggest things for me. I think it's really hard when when you have a cancer diagnosis and you're walking into that office for the first time. And for me, I just really try and empower people to know that there's things that we can do. There's lots of steps ahead, but we're going to walk through them. So at least, there's always unknowns, but at least we know that there's a plan in place, because I think that has some comfort in it, that we have things that we're going to work towards doing.
That's so good. That's so good.
Yeah.
I think for me, giving yourself space, I think, to actually feel and really to process what's happening, is really, really just probably the most important thing, because it is a dramatic change from everything that you've probably been through before. And a lot of times I think a lot of people don't get the chance to do that. And especially we as women, we don't, we're constantly thinking about everyone else, and we always prioritize ourselves last. And so that thinking kind of stays with you even when you're sick, which is very unfortunate. And we kind of need to stop and take a moment and like know that that's okay, for us to be able to do that and just say, you know what, it's okay to feel these feelings. It's okay to take a beat. It's okay to step away. You don't have to answer every question. You don't, you need people around you who are really going to be supportive and who aren't going to just throw every thousand questions at them that they can come across, or all of the research that they've looked at themselves. I did a PSA for ASI, and it was in one of the one of the scenes. I'm sitting at a table and I'm talking to my friends and my actor friends, and they're all kind of like talking to me, and I'm just kind of just like sitting there while they're like, oh, being all crazy. But that's what happened to me. And even now, my friends will call me and they'll be like, I read this thing about cancer, endometrial cancer. And then they always try to give you their point of view and their advice. And sometimes it's not needed. Sometimes you just need someone who's just going to be there and just listen to you and understand you and let you vent and kind of just let you be. And I think the other part to that is, just talk to your doctors. Don't rush into anything. Don't, like, sometimes I know time is of the essence and you can't help that. But don't just rush into a treatment just because it's there. Get a second opinion. it is okay to do that. Your doctors will not be offended. You have to do what's best for you. And, I think if you feel confident in your doctors will feel better. Um, I think that's it.
Yeah, I totally agree. I mean, I think like the concept of getting a second opinion, I really think it is so valuable because, you put so much trust in one person, and usually that is a person that you have met like one or two times, sometimes one time, and then they're doing a major surgery on you. And I think it's really, really important that you feel that that person is a good fit. And I think there are, as I said earlier, there's so many treatment options for endometrial cancer. Even just over the last like 5, 10 years, like we now have immunotherapy. We used to just give it in patients with recurrent disease that has now moved to the front line. We have newer classes of medications. We have many clinical trials. I mean, there is so much in this space, which is amazing. But I think you have to feel comfortable in your care and you have to feel like you're doing everything for you. I always tell patients, like, we get one really good shot at this. And so most of the time when, like, if my patients are going to get a second opinion, I encourage that. I tell them I'm never going to be upset. And most of the time they'll go and get a second opinion and the people agree. And then we all can, the amount of like comfort that they find in that is invaluable, really. So I really support second opinions. I think that you should never feel like that's something that that you can't do.
Mm.
Okay, but before we turn it over and turn to the questions from our audience, I want to give you, a moment to share anything else that you want, that you feel is really important for our viewers to know. For you.
I would just say, I think, the conversations like these are happening, and I think that looking and trying to find or aligning with organizations just like this that are doing this work. There are a lot of people that are doing this work. There's a lot of people that are in the advocacy space. Find those people, and if you have your doctors find those people and or help you locate these people too, because they're going to add to your network, and it's going to everybody needs an advocate. Everyone, you know, there are a lot of people out there that show up to the hospitals, and I would be in the treatment room, and I would see them by themselves. But there are a lot of people, there are a lot of organizations and advocacy groups that are here for you. So just know that you're the most important piece.
I would agree with that completely. And I think one of the things too that's really helpful is, every cancer is different. And now we're learning so much more about the way that people's genetics, not only in their bodies, but in the tumors, impact treatments and what would be good treatments for certain people and not others. And that could be a whole different webinar because there's so much to talk about. But I think there's a lot to be said for like really trying to understand what is going on with your own cancer and your own tumor. And I think sometimes patients feel like getting on my chart, looking at your pathology report, asking your doctor questions about all those little words that you might not understand. We have a lot of, you can take some of those words and you can put them into Google, you can put them into Chat GPT. There's a lot of really amazing resources to help understand these things because I think for these types of situations, like, knowledge is power. And I think if you feel like you understand and you get what is coming and there's a lot of comfort in that too for people. So I think that would be one of the things I would say. And then I think as another side note, like going back to our conversation at the beginning, you know, we know that most endometrial cancers, if they are caught early, have a really, really favorable prognosis for people. And so, making sure that, like, if you have abnormal symptoms or you know someone that has abnormal symptoms, they should get that checked out. No bleeding is normal after menopause. And so just really, that's something that I wish every person knew. Because I think there's just so many women out there that they're like, I didn't ever stop bleeding and I just thought that was okay because my mom did that. So just telling everyone that will listen, if they have abnormal bleeding, that's a really important thing to get checked out.
I have one last thing. I would also like to add to that. I think that that is so fantastic. I just want to reiterate that cancer is not the end. I think when we hear a lot of these conversations, even on the news, they're talking about it, science, all of these different outlets, but cancer is not the end for you. I think, again, like we're looking at Dr. Chambers, she is a perfect example of great doctors. I hear, people speaking about their experiences, and some have been very negative, but there are really some really incredible doctors that are out there that are here, to help. And I think everything that you said is just so spot on. And thank you again for this conversation. It was really, really empowering.
Okay, well, thank you both, but we have two questions in the Q&A. One is for you, Shanda, and the other one is for Dr. Chambers. The question is, I'm sorry, it says Marcy would like to answer this question. I'm not sure. Can you explain about being a 4-time cancer survivor, about reoccurrence, and reoccurrence after a hysterectomy?
Sure. So I was diagnosed in 2012 with, and like I mentioned earlier, with stage three endometrial cancer. It was quite aggressive. I had my first round of chemotherapy, and the tumor did shrink. It was almost gone. In fact, I had surgery first. The hysterectomy removed 95% of the cancer, and that 5% was gone. That's stubborn little 5%, I'm telling you. But we then moved into a course of chemotherapy, and it essentially went away. But, a lot of times we don't realize how microscopic cancer cells can be. And so over time, and I'm sure probably my environment, whatever I was eating, who knows, time, the cancer came back and I had my first recurrence. And that's when, and so I actually, I'm actually trying to remember. So I didn't feel any different when I had the recurrence. But I was on a course of every 3 months having a checkup. So I was going in constantly. One thing I did notice, and I did not talk about this before, was that I was in a high stress situation at work because I'd gone back to work after healing and some time had gone by. And I was right back to work and everything was great. And I was stressed at work. And I've noticed that as a commonality that each time my cancer did come back, I was in high stress situations. So I mean, that's just my experience and one of the thing that I noticed the most. Um, but I had recurrences consistently. I had maybe like a year later it would come back. I also wonder too, and maybe Dr. Chambers, you may know something a bit about this, but I had a hysterectomy, but it I believe that my hormones left slowly. So there probably may have been some chance that there was still estrogen in there and then potentially it could have grown the tumor or something like that. I will also add that we have to look at what we're eating as well because I've noticed how many hormones are in our food and there's a lot of like hormones that or substances that mimic estrogens that are in foods and things that we use every day. And so that could also have been a factor.
I can add a little bit more as well from like the different perspectives. So we know that when a person has cancer, we if we remove that cancer surgically from their body, there's still a risk that it can come back. And we don't really understand why that happens, but we think it's related to these microscopic cells that can sort of hide or sort of go to sleep in our bodies and then can somehow be reactivated. So for uterine cancer, if it's early stage, we take the uterus out, we look at all those factors, we make a plan, and when we give radiation and chemotherapy, we're usually giving it preventatively. And I always tell people the goal of it is sort of like an insurance policy to decrease the risk of recurrence. And these treatments after a hysterectomy, whether it's radiation or surgery, they are designed to decrease that risk of recurrence with the idea that there are these microscopic cells that may have escaped that we're treating with the treatment. But we don't really know for sure what it is that triggers these cancer recurrences. And that is like a really interesting ongoing source of research. We think there may be something about how cancer cells can sort of hide in our bodies, and they're able to hide from our immune system. So our cells don't know that they're abnormal to fight them. And that is actually one of the ways that immunotherapy works. So immunotherapy works different than chemo, and that it goes into our body and empowers our bodies and our immune system to fight our cancer cells, basically sort of telling our T cells and our white blood cells, hey, go find that cancer cell and kill it. And that's how immunotherapy works. So I think that was a very long answer to, there's a lot of research really trying to understand, because if we could prevent those recurrences from ever happening, that's the cure, right? So that's our goal.
And I'll say that toward the end, so my last treatment was immunotherapy. I think I mentioned that before in 2018. And since then, I have not had a recurrence. So I've been in remission since immunotherapy.
And I mean, immunotherapy is so amazing. It is a fantastic treatment. Initially it was first looked at in patients that had a recurrent disease, and now it has approval really for most people with endometrial cancer at some point in their journey, whether that's at the beginning treatment in certain patients or at the time of recurrence. So, and it definitely works. It has a different mechanism of chemo in that it really works with our own body's white blood cells to go in and fight our cancer. I was also going to add something about what you said about like hormones and food and diet and things like that. And we know that many endometrial cancers are estrogen positive. So the idea behind that is these cancers have these little sort of docking stations on them that when there is estrogen that binds to it, it makes the cell grow. And so we don't really understand that, but we know all of us have estrogen in our bodies, whether it's from, we know our adrenal glands, our fatty tissue, but also, again, like you said, in some of the food we eat and just like some of the hormones and things in our environment. And I think it's a really understudied area. And people ask me a lot about that, like what diet should I do? What exercise should I do? And there's not a lot of like high quality research in that space. What I usually tell people is to try, I think we all have a way that our body feels best, it's like the stuff our grandma would have told us,
Right.
like getting good sleep, eating the stuff around the sides of the grocery store,
Drink water.
drink water, not eating things out of packages. So and I think it's hard, like obviously when people have cancer, and I was telling everything's in moderation. Like you want to eat the ice cream, you want to get a shake, you want to have something that you enjoy, you should. Because I think those one-off choices aren't going to make the difference. But I do think that we do need a lot more research in that what else piece, because when we're giving chemo for 5 hours, there's a whole other 20 days that's happening.
Yes, thank you. We could have coffee and keep this conversation going because it's great. But I want to get to one more question, and we have just about a minute. But I want to get to this participant question that says, are studies showing more cases of early onset endometrial cancer?
They are. So we know that endometrial cancer as a disease is not only rising in people being diagnosed, but it's also rising in people dying from it too, which is a really big deal. But in our current time, we should be going the other way. So, and that over the last couple of years, endometrial cancer has now surpassed ovarian cancer as the most deadly GYN cancer. So there is a lot of work to do, but we know that both in young patients, so young premenopausal patients, and then also in older patients too, the incidence is increasing. And we know that many of those younger patients are being diagnosed because of genetic mutations in their families, like Lynch syndrome, like Shanda talked about. But then there are other risk factors too. We know when patients have a higher BMI, obesity, infertility, PCOS, and then again, just talking about some of the lifestyle things that we don't fully understand. But there is, I think one of the things that has been really talked about a lot more lately is young people being diagnosed with cancer and like bringing more attention to that why. And I hope that in the years to come, we really have more to sort of understand that to make changes.
Thank you both. Thank you, Dr. Chambers and Shanda, for joining us today for this webinar. Thank you for our sponsors, Merck and ASA, for their generous support of this event, and to our program partners, Ikana, for their collaboration and support. This event has been recorded and will be made available on Cancer Support Community's webpage that is posted in the chat. Thank you again, all of you who joined us, and we look forward to seeing you at our next webinar.